Okay, welcome and thank you everybody for joining us today. We're about to begin. This is Christina Honeysett speaking. I am the Director of Public Relations here at Vital Strategies. Vital Strategies is a global health organization that works with governments and civil society around the world to tackle their most pressing public health problems. Our speakers today are Dr. Tom Frieden. He's the president and CEO of our Resolve to Save Lives initiative, which I will tell you more about in a minute. We have Amanda McClelland, Senior Vice President of our Prevent Epidemics team, and Dr. Cyrus Shapar, Director of our Prevent Epidemics team at Resolve to Save Lives. The Prevent Epidemics team at Resolve to Save Lives partners with low and middle income countries to prepare for epidemics. In January and February, they were among the first to warn of and call COVID-19 a pandemic. On January 28th, Dr. Frieden said, quote, "The possibilities here go from the bad to the very, very bad," end quote. 6 weeks ago, on February 20th, the Prevent Epidemics team released a strategy to fight the pandemic. And 3 weeks ago, they released their model on the impact of the virus with up to 1.6 million deaths in the United States. On March 10th, they outlined a war strategy, and on March 25th, they outlined how to think about reopening society safely. Our Prevent Epidemics team provides an outside of government, science-based public health perspective on infectious disease threats. This perspective is informed by the deep expertise of our team, the work the team is doing in dozens of countries in Africa, and our experience as an organization registered and working in China. Having been ahead of the curve in both understanding and responding to the pandemic over the past months, today they will focus on what's next in the COVID-19 response. I will now introduce our first speaker today, Dr. Tom Frieden. Dr. Tom Frieden is a former director in the U.S. Centers for Disease Control and Prevention and former commissioner of the New York City Health Department. He is currently president and CEO of Resolve to Save Lives, an initiative of Vital Strategies funded by Bloomberg Philanthropies, the Chan Zuckerberg Initiative, and the Bill and Melinda Gates Foundation. Resolve to Save Lives works with countries to prevent 100 million deaths from cardiovascular disease and to make the world safer from epidemics. Resolve has recently received additional funding from Bloomberg Philanthropies to scale up its work in Africa. Just a note for those joining us today on the line, everyone at this time is muted, and we ask that you stay on mute until we open up for questions later on in today's briefing, at which point my colleague, Ali Davis, will call on you. If you have a question during the briefing, you can either enter it into the Zoom group chat or raise your hand via Zoom. For those of you who have dialed in, you can dial *9 for the raise your hand function. We are going to get through as many questions as we can. When we call on you, Ali will announce your name and affiliation. She will unmute you, and you can then ask your question to our speakers. And with that, I will hand it over to Dr. Tom Frieden.
Thank you. I'm joining you today from my home in Brooklyn, New York City, where the streets are empty, but the sound of ambulances and sirens is a grim reminder of the death rate, which has spiked from COVID-19. There have been already more than 1,000 deaths in New York City. And to give you a sense of scale, that's just in a few weeks, more people than die from either breast cancer or prostate cancer in this city, two of our leading causes of death. Friends and colleagues of mine are on the front lines, either caring for patients or struggling with this virus. And it's heartbreaking to learn of our nurses and doctors who are becoming ill. This is a crisis that drives home the fact that we're really all connected. What each person and each country does can affect every person and every other country. Fighting the pandemic is hard. The decisions facing governments around the world are life and death. I've been there. I know that there is a fog of war reality to the information, advice, and decisions that need to be made. Outside of government, we have the opportunity to provide a perspective on what needs to happen now and in the days, weeks, and months to come, and to learn from colleagues around the world, including through our office in China. Here's the bottom line. Americans and people around the world are doing what they need to do to flatten the curve, staying home. But for governments, healthcare, public health organizations, and all who can support them, this is not the time to wait, it's the time to work. We can save lives and restart our economy by asking the right question and getting the answer right. It's completely understandable that everyone wants to know, when can we go out again? But the question that we must answer is very different. It is, what do we have to do right now so we can reopen as soon and safely as possible? A key concept is that we need to reopen the faucet gradually, not allow the floodgates to open. Now, there's a slide that we'll put up on the screen now for those of you who are on devices and can see it. It will also be on our website. It's important to understand the phases of this pandemic. Here's where we are right now. There are 3 phases, and it's important to understand that our actions are different in each of these phases. But in each, there is a need for speed. Just today, we learned from China that the lockdown in Wuhan bought only 2.9 days for the rest of the country, and they acted that fast. That's the kind of speed we need to respond much more effectively than we have been for the past 3 months in this country. First, communities in this graphic try to contain new cases by rapidly isolating the sick and tracking people who those people came into contact with. You'll hear later from Amanda McClelland about the encouraging progress in Liberia, where they are an example of what every community must do. If cases increase significantly, as they have in New York City, then it moves to mitigation phase, in which physical distancing measures are put in place to cut down on the number of people spreading the virus. In many communities in the US, it's been necessary to implement tight restrictions to curb the spread of the virus and flatten the curve, with the goal of not exceeding healthcare capacity. Much of the US is in one of these first 2 phases. Some countries, including Singapore and China outside of Hubei, the province where the city of Wuhan is located, stay in the containment phase so far. When cases recede in New York City and elsewhere, as I'm confident they will in the coming days and weeks, we will move to the next phase, which we've called suppression. In this phase, there are fewer cases, but we need to act fast to prevent new clusters from exploding into another upward curve. If cases get out of control again, then tightening measures, physical distancing, will need to resume. Now, right now, we need to do 3 things so we can reopen as soon and as safely as possible. First, eyes on the virus, so we know where and how much it's spreading. Second, strengthen healthcare capacity, protect our front lines, the doctors and nurses, care for those who are mildly ill safely, and help those who need critical care. We also need continuity of care, personal resilience, helping people with coronary and other diseases which make them more likely to die from this. And third, we need to ramp up public health capacity, testing, focusing on turnaround time. How many minutes or hours does it take to get a test back? Understanding that this will be different at different times. And in the suppression phase, we may be aggressively testing even asymptomatic contacts. Contact tracing, enormously important. China has now done contact tracing of 700,000 contacts for 14 days each. We need an army of contact tracers in every community of the US to be ready to find every contact and warn them to care for themselves and stop spreading it to others. Isolation. We're going to have to encourage people, even with mild illness, to isolate themselves. And for people who can't safely be isolated at home because of other people in the home or because they're homeless or other factors, that needs to be in a dormitory or a hotel on a voluntary basis. Quarantine of those who are exposed but not sick, and figuring out how to rapidly and effectively implement physical distancing measures assessing what's working, feedback loops, so we can anticipate restarting sooner using things like mandatory hand sanitizer at every building entrance and temperature checks to the extent that those are helpful. How well and how quickly we do these things will determine how soon and how safely we can reopen. And when we return, we need to reopen the faucet gradually, not open the floodgates and risk an explosion of cases again. That means that people over the age of 65 and those with underlying health conditions will need to shelter in place for much longer, and that workplaces may open gradually with fewer staff, staggered hours, physical distancing in the workplace, and mandatory hand sanitizer at entrances and elsewhere. My colleague, Dr. Cyrus Shapur, will outline the criteria we propose for making that crucially important decision of when and how to reopen the faucet.
Thanks, Tom. Our team has done a review of the evidence base for reopening society after experiencing an influx of COVID-19 cases. We will now show the document. It was sent to you in advance. There are clear criteria in 3 categories that should be met before restrictions are loosened, including epidemiology, the who, when, and where of disease. We have proposed 5 measurable objective criteria. As one example, are cases decreasing over the past 14 days as the ability to test increases? The healthcare system, is it properly prepared to handle an increase in cases without risking the lives of healthcare workers and patients? Here we have proposed 7 criteria. For example, do you have enough personal protective equipment for healthcare staff and face masks for patients? Should the amount of patients double? Public health capacity, can we find and isolate cases and contacts, control the spread of disease, and resume physical distancing rapidly if needed? Here we have proposed 6 criteria. For example, can you test at least all symptomatic contacts of known cases? These are just a few examples of the benchmarks that need to be met in each of the categories. Once all criteria in these categories are met, society can slowly start to reopen. Older and medically vulnerable people need to shelter for longer. Communities can partially reopen businesses, such as daycares, so people can get back to work, as long as people continue to wash their hands, stay home when sick, and isolate if they are confirmed to have COVID-19. If 4 to 8 weeks after the initial reopening, there hasn't been a significant increase in cases and the criteria are still met, that triggers another tier of reopening, including reopening restaurants and bars with social distancing recommendations and good cleaning practices. And if there is a continued decrease in cases and the criteria met 8 to 12 weeks after the initial reopening, it could be time to pause restrictions on mass gatherings. But if cases increase significantly, communities will need to implement physical distancing restrictions again and work on flattening the curve. There could be a series of closures and reopenings while we wait and hope for better treatments and vaccines. I'll now hand it over to my colleague Amanda McClellan to discuss how low and middle income countries, particularly in Africa, are preparing.
Thanks so much. Thanks so much, Cyrus. At Resolve to Save Lives, with our colleagues at Vital Strategies, we are now working across the entire continent of Africa and beyond, 61 countries in total, to help governments flatten the curve. We're also working with the Partnership for Healthy Cities, a global network that provides support to 70 cities through practical information and tools to enhance local efforts to combat COVID-19 and to share best practice. Our support so far includes advising on and setting up disease surveillance and epidemiological analysis, sharing best practices for communicating with the public during a crisis and developing global information campaigns, providing legal authority and analysis and guidance to governments, and non-pharmaceutical interventions, community mitigation strategies, including those that Dr. Shapara just discussed, and we're adapting those for the African context. However, we see many African countries working hard already to make the most of this important phase. For example, Liberia is using the hard-won experience from the Ebola outbreak and is moving fast and aggressively using contact tracing and testing to confirm only 3 cases in Liberia so far. These lower case numbers in some African countries are not an indication that they can relax. There is no country in the world that will be protected from COVID-19 without preparing and responding quickly. But the implementation of these restrictions will be difficult in countries of lower and middle income status. It's difficult to implement non-pharmaceutical interventions that can mean the difference from staying at home and not getting COVID or going to the market and choosing to starve. It's critical local leaders listen to their communities and adapt to their environment to minimize risk of exposure, but also ensure basic needs are met. The coming weeks will be a trying time for our colleagues in Africa, but there is a strong sense of heeding the warnings from Africa and from Europe and the US, and hope that they can get ahead of the curve. I'll now hand it back to Dr. Frieden for closing remarks.
Thanks, Amanda. The bottom line, this is an emergency, and we need to act with that sense of urgency to ready our public health and healthcare systems for the series of COVID-19 waves that will inevitably be coming. It's a question of short-term economic pain for long-term economic and health gain. But for this to happen, we can't just wait for cases to ebb. We must urgently meet benchmarks such as those that we outlined today, the triggers for when we can loosen the faucet as soon and safely as possible. It's not about when we can reopen, but what we have to do now to make that day come sooner. This is World War C. We are in a battle with coronavirus. We all have a role to play to protect our healthcare workers and each other. Decisions to reopen society should not be about a date, but about the data. And today we've suggested a clear path forward with criteria and triggers to follow. As long as we all work together, we can save many lives and protect our society and economy. But even if we succeed here in the US, if it's not controlled elsewhere, we will be much less safe. And we need to continue and deepen our engagement with countries around the world to learn, to share information, and to partner in this war. I believe that people have understood the importance of staying home to flatten the curve, but the second part of that equation has often been lost. The reason we're doing that is also so we can ramp up our ability to track the virus, care for patients, and trace those who have the illness and their contacts so that we can prevent the kind of re-emergence of explosive spread such as that which we're seeing in New York City today. I thank our very generous donors for the opportunity to do this work, and I encourage you to visit preventepidemics.org to stay up to date on our latest analysis, including how prepared each country with cases is to handle a COVID-19 outbreak. That website also has the documents that we circulated today, which are three basically. First is the diagram, which expresses the different phases and what needs to be done at different times, and the triggers document for when to tighten the physical distancing restrictions and when to loosen them and how to do that most safely. Ali, over to you for the question and answer portion of the briefing.
Thank you, Dr. Frieden. To everyone on the line, the documents shown during this briefing will be shared shortly after the call and are already available on preventepidemics.org in our Coronavirus Insights page. We'll now move to the Q&A. Everyone at this time is muted. If you have a question during this briefing, you can either enter it into the Zoom group chat, raise your hand via Zoom, or dial *9 if you're on the phone. I will call on you when we reach time for your question. When I do call on you, I'll announce your name and affiliation, unmute you, and you can then ask your question. We'll start with our first question from Morgan Chalfant at The Hill. The question is, the White House released modeling yesterday projecting that 100,000 to 240,000 Americans would die due to the coronavirus if social distancing guidelines are followed. Do you think this projection would be lower if the administration had better testing in place or taken other steps early on that were not taken to stop the spread of the virus? And what would those steps be?
3 weeks ago, Dr. Schopper and I published our estimate that there could be up to 1.6 million Americans killed by this virus. So the projection that the White House cited in the past few days is not a surprise. All of us in public health have known this for weeks. I think rather than think in the past of what should have been done differently, we have to think forward of what we must do now, because the future is within our grasp. We can change what happens. I think we should definitely aim for a number substantially below 100,000. Even a single death is a death too many. It's somebody's mother or father or brother or sister or friend or neighbor. And it's crucially important that we work right now with that speed that the most successful countries have worked with to do what's needed today, tomorrow, and in the coming weeks. What I see is an obsession with one particular action or another, rather than a comprehensive approach, well organized, to address each aspect of this response. And what gets me most concerned is not seeing the Centers for Disease Control front and center in the decisions and the communication of those decisions. Let's be frank, they are our #1 experts in how to address a pandemic of respiratory illness. The CDC has more than 20,000 health professionals working there. The National Center for Influenza and Respiratory Disease has more than 700 of the world's best experts in how to do this. And I want to take us back for a minute, since the question is about the past. Dr. Nancy Messonnier is the head of the National Center of Influenza and Respiratory Disease. Dr. Anne Schuchat is the former director of that center. I'll give you just a couple of things that Dr. Messonnier said in the past 3 months. On January 26th, we need to be preparing as if this is a pandemic. What was happening on that day throughout the federal government? Were we ramping up respirator production, elastomeric half-face mask production for N95s for health worker protection, intensive care unit training, production of thermometers, hand sanitizer, training of contact tracers? On February 7th, we recognize the uncertainty of the current situation. This comes down to need to be humble. It is premature to comment on whether it has slowed. February 7th, nearly 2 months ago. On March 21st, I'm sorry, on February 25th, more than a month ago, we want to make sure the American public is prepared. Disruption to everyday life might be severe. We as a family ought to be preparing for significant disruption to our lives. If all of us had been hearing from Dr. Nancy Messonnier every day for the past 5 to 6 weeks, we as a country, as families, and as individuals would be much better prepared. And going forward, it's crucially important that our top disease fighters, the CDC, is central to this battle.
Thank you, Dr. Frieden. Our next question comes from Shen Wu Tan at the Washington Times. I would like Dr. Frieden to share his thoughts about the CDC debating on changing their recommendations to include wearing face masks. What does he think of this? Why is the CDC debating this? And if the CDC does change these guidelines, will they help protect the public and prevent further spread, in his opinion?
It's understandable that whether or not to wear a mask when you go out is top of mind for people. It's also important that we understand that this is a complicated question and it's going to vary. There's a hierarchy of what's important in terms of masks. First and foremost, our healthcare workers who are on the front lines of the battle against coronavirus need to have the best respiratory protection possible. That's an N95 mask, and if those aren't available, a surgical mask. These are crucial for healthcare workers who are interacting with patients in hospitals, and it's important for healthcare workers to wear routinely because they're at high risk for exposure. There may be a benefit of healthcare workers using a mask at all times in case they're infected to reduce the risk to the susceptible people, other healthcare workers and patients around them. So in a hospital is one thing. Anyone with symptoms should be wearing a mask or other face covering. Can be a scarf or bandana if they have to go out and when they're getting care. That means a form of what is known as source control, reducing the amount of infectious virus that gets out into the community, into the environment. Patients who are sick need to wear a mask. And for many hospitals, it makes a lot of sense for all patients and all workers to be wearing a mask at all times. Now, when worn by people who are ill or people caring for an ill person in their own home, masks can help reduce transmission. But I think the question everyone is asking now is, should everyone be wearing a mask? I was taking a walk in my Brooklyn neighborhood the other day, and I saw so many people wearing masks, and I wondered to myself, what is the reasoning there? Many of these people are not going within 6 feet of anyone. So what's the benefit of a mask in that situation? We all want to do something. There are ways in which wearing a mask could be helpful, and there are ways in which it could be harmful. And I'd like to take us through that. And I think this is the kind of conversation that is so important for us to have. So it may help because if you put a mask on someone who's ill, they are less likely to spread the virus to others. That includes people who don't have symptoms. And we know that people who don't have symptoms can potentially spread the virus. So by putting a mask on yourself, you may be protecting others. In fact, in Asia, before COVID, it was very common for anyone who didn't feel well to wear a mask when they went out. That's a good practice. That protects the people around us. There is some evidence that wearing a mask may protect people against exposure if you're not sick. However, doing so could also do harm in 4 different ways. First, if you're taking material from healthcare workers who need it, that's a problem because they may not be there when you need their help. Second, wearing a mask may lead to your touching your face more because it's uncomfortable, and that may actually increase the risk that you infect yourself from a contaminated finger or hand. Third, the moisture of a cloth mask may result in the buildup of viruses and bacteria on that mask. In fact, at least one carefully done study of healthcare workers who were given cloth masks found that it increased the likelihood that they would get influenza virus infection. And fourth, it may give a false sense of security. Even if you're wearing a mask, you shouldn't come close to other people unnecessarily. You need to wash your hands regularly. You should not go out if you're ill unless that's absolutely essential. Thank you.
Thank you. And our next question comes from Julie Steenhausen at Thomson Reuters. Is there a mechanism on the federal level to invoke crisis standards of care? Who decides to put them in place?
Crisis standards of care are generally done at a state-by-state basis. The CDC has issued guidelines for this desperate situation that many hospitals are in on how to most safely reuse scarce protective equipment. It's a situation none of us would like to be in right now, but the fact is we are. So we need to take steps to care for patients as safely as possible. Fundamentally, there are 4 things that healthcare facilities have to do. First and foremost is protect their own patients. And with all of the appropriate focus on the importance of personal protective equipment, we also need a focus on what's known as the hierarchy of interventions, administrative, engineering, and other controls that reduce the likelihood that anyone will get infected. That means tents outside, that means ventilation, that means policies and procedures that put a mask, for example, on every person who comes in. So the first thing healthcare facilities have to do is to be safer for the healthcare workers. The second is to have a way of taking care of large numbers of mildly ill people. In New York City today, we're strongly encouraging people who are able to breathe okay, even if they have cough or fever, to stay home. Anyone who doesn't need to be hospitalized needs to stay home, because if they go out to get care, they may infect someone in the course of going out or getting care, use up scarce resources, and in the end, they're just going to be told to go home and isolate themselves. So the second key for healthcare facilities is a way to treat large numbers of patients. And there are examples of where the federal government does need to make a change. For example, there's a rule, EMTALA, I believe it's called, that requires the emergency department to assess individually each person who comes in. There may be a need to treat people without the regular charting that's done, to rapidly triage, to kind of drive through testing that we saw in South Korea. Third, healthcare facilities need to ramp up their ability to care for people who need critical care, intensive care, ventilator support. That's not just about the number of ventilators. I have a long-term friend and colleague who's here at New York City. His hospital ICU is now full. And the gap is not ventilators, it's people to operate them. It's intensivists, people who know how to manage desperately ill patients. This is not just one piece of equipment, it's a whole system to support patients safely. And the fourth, we can't lose sight of, it's continuing the ongoing healthcare needs for people with diabetes, hypertension, seizure disorder, women who need obstetrical care, children who need care. There is a need to keep our health system going. And a painful lesson from Ebola in West Africa, where more people died because of Ebola than died from Ebola, whether from malaria, tuberculosis, childbirth, or the lack of routine healthcare. We need to ramp up telemedicine. We need to figure out how to do more medicine as we're learning how to do more schooling and more working from distance. And these are things that the healthcare system needs to do and that the federal and state levels need to support. To give you one positive example, very rapidly, Medicaid released very appropriate guidance for telemedicine, making that much easier. And we're seeing that trend all over the world. Maybe this is one good thing that will come out of this terrible tragedy, a more efficient use of our healthcare resources.
Thank you. Our next question is from Hillary Bruick at Business Insider. Dr. Frieden, you said we need an army of contact tracers in the United States. Can you talk a little more about how contact tracing is working in the United States right now? Do we have enough public health workers to do this? And how should the country be beefing up its army and at what level, state, local, or federal? How does our system compare, say, to Singapore?
This should be front and center for every community in this country. Contact tracing is a core public health activity. It's bread and butter for public health, and it's an art and a science. The most instructive example, I believe, is from China, where the city of Wuhan, with 11 million people, had 1,800 teams of 5 people. That's 9,000 people doing contact tracing. Now, by training, I'm a tuberculosis specialist. In tuberculosis, we do a lot of contact tracing. You talk with the patient. You identify the exact potential infectious period. In COVID, that would be from 2 days before symptom onset until we believe the patient was isolated or no longer infectious. And then you go through every moment of those days to see who they spent time with and what that person's information is. And then you find those people, warn them that they have been exposed, advise them to be isolated because they are being quarantined, and help them, if they get any symptoms, to be tested immediately. That effort is currently being assessed and needs to be urgently ramped up everywhere.
Great, thank you. Our next question is from Dan Goldberg at Politico. Do you have a sense of where the next hotspots are based on your knowledge of critical care beds around the country? Are there other cities in danger of looking like New York City?
Every city is in danger of looking like the challenges we've seen in Wuhan, in Italy, and in New York City. There is no city anywhere in the world that can withstand an outbreak of coronavirus that will occur if there isn't very, very rigorous physical distancing, sheltering at home. So every city needs to be ready. Sometimes it's just a matter of chance. There was a meeting, there was a group, there was an individual, there was an exposure. One of the things that we've learned about this, very interesting, from Singapore, which has a superb health department, is that in one careful analysis that they did, and we need more epidemiologic understanding of this, in one careful analysis the Singaporean experts did, 85% of people with COVID-19 didn't spread it to anyone. But of the other 15%, some spread it very widely. I think people have now heard the term R0 or R0. It's a simplification. It's a mathematical simplification of reality. And the reality is that people are different and that some people spread this very widely. That's why speed is so important, to identify the contacts, to see if they're sick, and if they are, to expand that circle and test more people. I think that really there are important lessons to be learned from countries all over the world, and the quicker we learn them, the better we can protect Americans.
Thank you. Our next question comes from Jesse Hellman at The Hill. There are outbreaks of COVID-19 at more than 400 long-term care facilities across the United States. What factors are playing a role into the spread at these facilities? What more could the federal government and states be doing to stop these outbreaks at these facilities? Also, we don't know how many total confirmed cases there are at these facilities or the names of these facilities because the CDC doesn't release that information or doesn't collect that information. Should it be collecting that information?
More than a month ago, I called nursing homes and long-term care facilities ground zero for COVID-19 and urged that all visits to these facilities stop. The experience from Kirkland, Washington was a warning. It's what we call a sentinel health event. It is a sentinel for what was inevitably going to happen nationally. Every single one of these facilities needs to do everything possible to protect the people living there. That means no visitors for the foreseeable future. It also means no sick healthcare workers. It also probably means all healthcare workers, all staff there need to wear a mask at all times. It means hand sanitizing every single interaction. It means better environmental contamination, because we know that COVID-19 is spreading like a super SARS. It spreads in all of the same ways SARS spread and more. That means that it is present on doorknobs, elevator buttons, IV poles, bed rails, and hospitals can only stop it. Nursing homes and long-term care facilities can only stop it if they get all of the details right. But here again, Singapore shows reason for hope. In their healthcare facility where they've cared for more than 300 patients, they've yet to have, as far as we know, a single nosocomial or hospital-caused infection of a healthcare worker. And not because they're using moon suits, but because they are using meticulous attention to detail. And that kind of meticulous attention to detail is crucial for every single residential and healthcare facility in this country. This means every person who enters, hand sanitizer. Every person who's there, temperature check. Every staff member needs to protect themselves from exposure and not come in if we're sick. We know how terribly, terribly fragile in respect to this virus, people who are over the age of 60 and people who are medically vulnerable are. We need to protect them from exposures. And when there is an outbreak in a nursing home or long-term care facility, then we need to follow the CDC's guidance on what can be done to reduce the terrible impact that it will have.
Thank you. Our next question will come over the phone from Anjali Kamlani at Yahoo News. Anjali, I will be unmuting you right now.
Thank you. Dr. Frieden, good to talk to you again. I wanted to just get your thoughts on, just responding to this outbreak, the U.S. response to the outbreak, and what is going on when it comes to the level of health experts that we're able to get access to from the administration, considering the fact that so many former administration officials like yourself have been able to be the source of information. Your thoughts on that and your role there?
What's crucially important is that we hear from the CDC. The CDC is the nation's health protection agency. They have the world's experts in the control of respiratory disease. And I will feel safer when we're hearing from them every single day. Fighting this war without CDC front and center is like fighting with one hand tied behind our back.
Thank you. Our next question is from Betsy McKay at the Wall Street Journal. Given the emerging science so far, what do you believe is the main route of transmission? Aerosols, fomites, how much of either?
Thank you. With infectious diseases, there is often what I call the slippery slope to zero risk. We have a few rules in medicine. One of them is that common things are common. There will be exposures and infections from contaminated surfaces known as fomites. That's why cleaning of commonly touched areas like doorknobs and elevator buttons is so very important. And there will be some spread from people who don't have symptoms, asymptomatic people, either because they haven't developed the symptoms yet, or because they may never feel so ill that they feel that they have symptoms. But our best understanding of this, based on a review of all of the science, is that the great majority of spread will be from symptomatic people. What we've learned about COVID-19, and we share this each week, rounding up the science from all around the world with a weekly science update that Dr. Schopper and his team put together on our preventepidemics.org coronavirus site, is that the most infectious people are those in the first week of illness. That's very different from SARS, and that's why I called it a super SARS when it comes to infectivity, because that means that just when people are starting to get sick, they're very infectious. That's why it's so important that we find people at the very start of their infection, isolate them, find their contacts, quarantine the contacts. And this may seem impossible, but it's necessary and it is possible. China is doing it, Singapore is doing it, and I have no doubt that we can do it, but we need a much more coordinated, focused approach, understanding not just what the challenge is today, but what it's going to be tomorrow and how we address it.
Thank you. Our next question comes from Lena Sun at Washington Post. Lena, you are now unmuted.
Thanks, Dr. Frieden. I had a question for you. As someone who is watching this from the outside, what specific data would you like to know about what the White House is basing, what the task force is basing its information on? Because they haven't really released that. They just come out and say this or that, and here's our projections, but you don't really see the underlying science or the data or their systems that they're relying on. What would you most like to know what it is that they are basing their pronouncements on?
There's a principle that CDC goes by to base all decisions on the best available public health data, openly and objectively derived. These are hard decisions. I don't want to be second guessing people from outside the government, but it's crucial that when a decision is made, the public learns all of the basis of that decision. That's generally what CDC has done. I think not having CDC at the table is frankly dangerous. I feel unsafe because I don't feel that CDC's deep and wide expertise in disease control is being fully deployed in this instance. But the kind of data we need to see is in a dashboard. In fact, we think there's a very clear and key way to track the main indicators of what's happening. This includes not only looking at new cases and deaths, number of lab tests and percent positivity, but also our intensive care beds. How many are occupied currently? How many of our usual census, what proportion of our usual census is occupied? What is the fatality rate? And that needs to be analyzed much more accurately than it's been analyzed so far. You need to look at everyone diagnosed 30 days earlier and what proportion have died. We need to see if we have good emergency management systems in place at the federal level and at each state and city level. I don't see it at the federal level. There's a basic playbook for how to deal with an epidemic. You have an incident manager, they control the response, they are aligned with political leadership, they tee up the decisions to be made, there are policies, decisions to be made. I don't see that happening, and that makes me really worried. I don't see us thinking a week, 2 weeks, a month ahead. This is not just a question of everybody stay home and hope this goes away when the summer comes. This is everybody stay home while those of us in public health, healthcare, and government work furiously with enormous speed and urgency, not just to get ventilators and masks out, but to get contact tracing up, to figure out how to safely isolate people who are sick. There are so many things that need to happen that I just am not sure that they're happening, and they're certainly not being communicated. If they're not being communicated, then the cities, the states can't get it done. I also would like to see a careful look at critical care capacity everywhere. I'd like to know how many healthcare workers are getting infected everywhere. We were critical of China for not publishing information on that, and we're not publishing it. I'd like to see information on what our surveillance is like. And we're seeing some very good data from what's called syndromic surveillance that allows us to track the increase. And that's how some of the experts saw the New York City increase happening in early March and were terrified by it. I'd like to know that the essential needs of our communities are being met. Our healthcare needs, are people going off their medications? Are we going to see more heart attacks and strokes and seizures because people can't get their medicines? I'd like to know to what extent people are understanding and adhering to recommendations and how they're harmful and how we can balance physical distancing with social solidarity. There's a need for a basic dashboard that's publicly available, and there's a need to publicly share all of the bases on which the decisions are being made. Thank you.
Thank you. Our next question is from Xiaofeng Wang. As you mentioned, we need eyes on the virus. How do we identify the people without symptoms and avoid the spread of disease in the community?
Asymptomatic disease and asymptomatic spread is a major concern. I think for some time, many of us wondered, is this happening? We didn't have the data. Now the data is clear. A significant proportion of the people who have the virus in their upper respiratory tract don't have symptoms. Many of those will develop symptoms in the coming days. Some of them will never develop strong enough symptoms to feel sick. So those are two different groups of people, pre-symptomatic people and asymptomatic people. We still don't know how much disease those individuals spread. And it's important not to feel hopeless about it. What China is doing is a lesson for all of us. They're testing massively. They're finding asymptomatic infections. And when they find a case without a clear link, they go back to figure out where that infection might have come from and what other people may have the disease. That's what we're talking about for the suppression phase and for the containment phase for places that haven't had explosive spread, as New York City is having now. In that phase, we need very aggressive testing. And I understand there's still real limitations in the availability and turnaround time of tests. That's being worked. I hope it will improve in the coming days and weeks, and it must, because when we get to that suppression stage, we're going to need to test massively, and we're going to need to contact trace massively. Yes, there will be asymptomatic transmission. That's why this is not a disease we can eradicate. We will not eliminate this until and unless we have a vaccine, but we can suppress it. We can prevent it from exploding. But to do that, we need a very different approach. We need aggressive testing, proactive testing, and very, very comprehensive contact tracing. These are core public health practices, and they're going to be essential to being able to get back to a new normal. We're not going to get back to the old normal, but we will get back to a new normal. And we can do that sooner if we understand that sheltering in place is just half of the equation. The other half is getting our tracking systems, our healthcare system, and our public health system ready for that new normal so we can keep cases down.
Thank you. And this is our last question from Yoav Gonen at the City. We'll make sure to follow up with reporters at press@Vital Strategies should they have any additional questions. His question is, there was a study published this week by an MIT economist that concludes New York City might already be flattening the curve of new cases because the number of new confirmed cases is no longer doubling. I'm wondering whether he thinks such a conclusion is reasonable or whether it's too early to say based on the available data. Has he seen any signs of hope in the New York City or New York data?
I do see some glimmers of hope in the New York City data. Cases don't appear to be rising as they were before. Unfortunately and tragically, what we see with this disease is that severe illness comes on about 5 or 6 days after infection, severe illness about a week after that, and death, sadly, when it does occur, about a week after that. What that means is that there's a 2 or 3 week lag between when spread of the disease stops and deaths begin to come down. We're going to see this get worse before it gets better in New York City and in many parts of the world and the country. But we are all in this together. And I do think that the social, physical distancing that we're doing in New York City is making a big difference. It's driving down transmission and giving us time to build systems to keep our health workers safe, to have eyes on the virus so we know where and how it's spreading, and to get ready for that massive testing, contact tracing, isolation, and quarantine effort that is going to be an ongoing aspect of our lives for many, many months to come. And in all of that, protecting the most vulnerable among us, particularly those over age 60 and who have underlying health conditions, and understanding that we are all in this together as a world, that what happens in any country affects all of us. Even if we control it now, we have globally seen more than 200 countries with this. And globally, if you correct for undoubtedly underdiagnosis, there have been more than 1 million infections with this virus. If this explodes in Africa, in Asia, and Latin America, we will not be safe. We're going to have to unite as a world and fight this virus as a world war, because it is a world war. There isn't an enemy here in people or in states or in countries. The enemy is a virus, a dangerous microbe. This is World War C. It's us against the microbes. And if we work together and work smart, we can limit the number of deaths and get back to a new normal, which will in many ways be a safer normal. So thank you very much for joining us. All of this information will be on our website. Please continue to send the great questions, to do the important reporting that you're doing. All of us benefit when all of us learn with each other, from each other, and work fast to protect people here, today, and around the world every day.